Professor Patel, thank you very much for that very kind introduction. I'd also like to thank Professor Mishra for this is certainly touching medicine and surgery, and I hope to illustrate how some of these things that we get from big data are affecting our everyday practice. So I'll start with Dr. David P. Winchester, who was a former chair of surgery at NorthShore. He has been actively involved with the American College of Surgeons Committee on Cancer and is probably the prime mover in the development of the National Cancer Database. So this is a joint program of the Commission on Cancer, the American College of Surgeons, and the American Cancer Society. It's a nationwide oncology outcomes database, and there are greater than 1,500 Commission on Cancer accredited cancer programs in the U.S. including Puerto Rico. 70% of all newly diagnosed cancers in the United States get included in this database. There are 34 million records from hospital cancer registries within it. The Commission on Cancer is a program of the American College of Surgeons which was started in 1922 to develop standards for the diagnosis and treatment of cancer. It approves facilities that are committed to providing the best cancer care, and these facilities get reviewed on a regular basis. Facilities have to have a cancer registry, which is the source of information for the National Cancer Database, the NCDB. It provides lifelong standardized information on all cancer patients. In other words, once a patient is entered, the registry is obligated to follow that patient and submit data to the NCDB. I show you this American Thyroid Association guidelines. Not to go through it all, but if you look at the number of pages in each individual guideline, sorry I don't have a pointer, but the top one there were about 7 pages and increased to about 30, 40 some. And our most recent guideline is now 133 pages, so it illustrates the complexity of what we do. So the first guidelines with regard to differentiated thyroid cancer was by Singer in 1996, and it suggested that if you had a less than 1.5 centimeter thyroid cancer, lobectomy versus total thyroidectomy were both appropriate treatments. Above 1.5 centimeters, total thyroidectomy was the treatment recommended. Then in 2006, David Cooper and other authors came up with a recommendation or guideline that tumors between 1 and 1.5 centimeters should be treated with total thyroidectomy, and central neck dissection should also be considered. This is the first paper that came out of the National Cancer Database dealing with papillary thyroid cancer. And it was by a group from Northwestern, headed by Dr. Bill Moria, who's been a regular user of the National Cancer Database. And it took 52,000 patients, and among these, there were 43,000 and some that were treated with total thyroidectomy. The point of this slide is to see the breakdown of total thyroidectomy and lobectomy. You see that lobectomy at this point was about 17% of the operations performed for papillary thyroid cancer. And what they found was that for less than a centimeter, the extent of surgery had really no impact on survival or recurrence. Above 1 centimeter in size, they found a greater risk of recurrence and death from lobectomy. And here you see the recurrence rates for patients with papillary thyroid cancer based upon size. No surprises here. The larger the size, the more likely the recurrence rate. And the recurrence rate was affected by the extent of surgery, with lobectomy having a significantly higher rate of recurrence. This data is very interesting because currently there's no data on recurrence in the NCDB that is present. So I'm not sure where the authors got this data from at that particular time. Relative survival rates after surgery showed, again, significantly improved survival with total thyroidectomy. And this had a big impact on what surgeons were being recommended to do. When this was looked at with statistics, you see that for patients with, all patients had a significantly higher rate of recurrence with lobectomy and a significantly higher survival with total thyroidectomy. Less than 1 centimeter in size, there was no significant difference. And when this was stratified by tumor size, greater than 1 centimeter, 1 to 2 centimeter, and 2 to 4 centimeter sized tumors all had a significantly improved rate of survival and lesser rate of recurrence. Now, the discussion of the paper came down to asking, how much benefit are you going to get? And the authors said they expected there would be just a 2% survival increase. So it really comes down to your opinion, is that meaningful or not? And the authors suggested that the complication rate should be less than 1% if you were going to do total thyroidectomy for tumors of this size. And I think surgeons certainly have accomplished that, or at least busy endocrine surgeons do accomplish that. So in 2009, the guidelines were changed a little bit, recommending for greater than 1 centimeter total thyroidectomy and suggesting a routine central compartment dissection. A number of studies came out around or just before this time or just after, questioning really, again, the extent of thyroidectomy, because total thyroidectomy had been widely introduced. And you see the use of the SEER, another large database, Memorial Sloan Kettering, and our colleagues from Japan suggesting that maybe thyroid lobectomy was appropriate, or more appropriate than what was being done. More recently, the group from Duke published the extent of surgery for papillary thyroid cancer is not associated with survival. And they, again, used the National Cancer Database, getting a little over 60,000 patients with tumors that were 1 to 4 centimeters in size. And here, you see that lobectomy from that 70% I described earlier was now being performed in only about 11% of patients. And when they looked at the initial data, there did seem to be a benefit in terms of survival with total thyroidectomy compared to lobectomy for tumors 1 to 4 centimeters in size. The benefit was greater, of course, in larger tumors. Tumors that range from 2 to 4 centimeters had a better survival than tumors 1 to 2 centimeters had a better survival than those at 2 to 4 centimeters. But then the authors went ahead and just adjusted for patient demographic, clinical, and pathologic factors, and the overall survival for total thyroidectomy compared to lobectomy in all patients with 1 to 4 centimeter tumors did not hold up. So they found a similar overall survival for total thyroidectomy and lobectomy for 1 to 2 centimeters tumors and for 2.1 to 4 centimeter tumors. So the ATA guidelines for papillary thyroid cancer again changed in 2015. And now less than 1 centimeter without extrathyroidal extension and node-negative tumors are being recommended to have lobectomy. Greater than 1 centimeter without extrathyroidal extension and node-negative, lobectomy or total thyroidectomy. So the pendulum has swung the other way now. Now this is data from one of my fellows. He went through the National Cancer Database, and the title of the paper is "Lobectomy is not sufficient for T2 papillary cancers," and this is just coming out in surgery. So out of 126 thyroid cancer patients in the NCDB, tumors 1 to 3.9 centimeters of classic papillary thyroid cancer or follicular variant of thyroid cancer were selected, and leaving about 33,800 patients. So among the classic papillary thyroid cancer patients, you see the rate of lobectomy now is down to 5.7%. With the follicular variant, the rate of lobectomy was about 14%. So in looking at lobectomy versus total thyroidectomy, there did seem to be a slight survival benefit with total thyroidectomy in the overall group of classic papillary thyroid cancer patients. With follicular variant patients, there was no benefit between the two operations. Both had a similar rate of survival. And then adjusting for similar patient and clinical factors, we looked at thyroid lobectomy and total thyroidectomy. And with follicular variant, it really made no difference between any of the sizes, whether it was the overall group or 1 to 1.9 centimeters or 2 centimeters and above. Now, adjusting for patient and clinical factors and so forth with classic papillary thyroid cancer, when you looked at 1 to 3.9 centimeter tumors, there was no survival advantage. When you looked at 1 to 1.9 centimeter, again, no survival advantage. And for classic papillary thyroid cancer, 2 to 3.9 centimeters, there was a survival benefit with total thyroidectomy. And you might ask, why is there no difference in the overall group? We'll get to this in some later slides, but in the United States, the number or the size of tumors is heavily weighted towards tumors less than 2 centimeters in size. So the numbers are overwhelmed with the smaller tumors. Now this is another, we're going to switch a little bit here. And this is one of my former fellows, Paritosh Suman, who is a graduate of Ames and is currently a surgeon in New York City. He questioned about the timing of radioactive iodine therapy and went to the National Cancer Database and took just high-risk patients, patients with tumors greater than 4 centimeters, positive lymph nodes, positive margins, so forth, and divided the patients into 2 groups, those who had radioactive iodine early on within the first 3 months after surgery, and those who had radioactive iodine treatment after that period in the first year. And there seemed to be a little bit of benefit in the early group, but actually none of this ended up being clinically significant. You see, again, a very small difference here, not statistically significant. So if you are delaying radioactive iodine treatment for whatever reason the patient might have, it does not seem to have a substantial effect on survival. He also looked at risk factors for central lymph node metastases in thyroid cancer. Again, using the National Cancer Database, his inclusion criteria were N0 tumors. Patients had to have near total, subtotal, and total thyroidectomies. And the whole list of exclusion criteria you can go through. So he was really trying to select out patients who had a prophylactic central neck dissection. He got almost 40,000 patients that he was able to study, and the ones who had positive prophylactic central neck dissection the number who had prophylactic neck dissection was about 60%, and who did not have a prophylactic central neck dissection was about 40%. His definition was a prophylactic central neck dissection with 3 lymph nodes removed was about 30%, and prophylactic central neck dissection limited to 6 lymph nodes or more was about 16%. So his findings here were that age, less than 45, males, Asian background, and tumors greater than 1 centimeter in size, each was significantly associated with likelihood of central neck metastases. So this data can be used if you're a person who does not do central neck dissections routinely, to do a selective approach to that procedure. My current fellow has been looking at the effect of age on staging of well-differentiated thyroid cancer. We've been talking primarily about papillary cancer up to this point. And if you recall, staging systems lump papillary and follicular thyroid cancer together. So in 1983, the second edition of the American Joint Cancer Commission put in a age factor as staging with a cutoff of age 45. The current 8th edition has increased that to age 55. And so he was trying to see, does age affect survival differently for these 2 types of thyroid cancers? Looked at that National Cancer Database, again, over a 10-year period. The inclusion criteria, stage 1 through 4 disease, both papillary and follicular. Excluded were patients with other malignancies, and if the age or stage was not known, endpoint primarily was overall, or primary endpoint was overall survival. He grouped the patients by 5-year increments, did appropriate statistics, including a Iodine index from the ROC curve to compute optimal age cutoff. So there were 204,000 well-differentiated thyroid cancers, of which 92% were papillary and 7 or almost 8% were follicular. So when you look at these data, it is clear that if you lump these 2 together, you're only going to get results for papillary because the number of papillaries so overwhelms the number of follicular cancers. Patient characteristics with regard to gender, there are more females in the papillary group. Extrathyroidal extension is more common in the papillary. Radioiodine is given more frequently to folliculars. And the follow-up was a little bit longer in follicular, but obviously a good follow-up. Key here, overall survival, or the overall mortality, 3.3% for the papillaries, 8% for the folliculars. And when you look at the age greater than 45, you see more are in the follicular category. The tumor size of the folliculars, the percentage of ones that are larger gets bigger as you increase from T1 to T4 compared to the papillary ones. And the nodal category, much as you'd expect, positive nodes are going to be more common in the papillary. The metastatic disease, 0.6% with the papillaries overall and 2.7% with the folliculars. So this is the mortality rate by age. See, there's a gentle rise in the mortality of papillary thyroid cancer. And it's hard to pick a particular cutoff for papillary. However, in the yellow line, you see there is a relatively sharp rise between 40 and 45 for mortality with follicular cancer. And this is just a breakdown of the statistics here, looking at the hazard ratios. The HR column, you see there is just a gentle change with the papillary, yet with the follicular between age 45 and 50, the hazard ratio changes by a factor of 2. So a large change there. And this is what I've just told you in graphic form. You see that large change in the hazard ratio. And this is these are graphs of the Iodine index. When we graph out the data we presented using the statistical formula, you get a optimal age for the survival with papillary cancer of 58 years for staging purposes and 46 for follicular. So he is currently looking at differences in papillary and follicular. We already mentioned that males more commonly compared to papillary cancer, or male gender is higher in proportion in follicular thyroid cancer, than in papillary thyroid cancer. If you look at tumor size, you'll see that the percentage of patients with larger tumors increases as the age increases with follicular thyroid cancer. With papillary thyroid cancer, the percent of tumors that are less than a centimeter in size slowly increases over time. There's really not much change in the large tumors with papillary thyroid cancer. N1 disease, again, more common in younger patients with papillary thyroid cancer. Not much change in this with follicular thyroid cancer. M1 disease or metastatic disease, again, slight increase over the age categories over time with papillary thyroid cancer, and this increases substantially with follicular cancer in the later years. Positive margins, more common in follicular, probably because of the larger tumors that you get when patients are older. I think we all understand that Hürthle cell tumors are of a worse prognosis, and the number of Hürthle cell tumors, the percent number, increases over time. With papillary, the percentage of follicular variant, of course, a better prognostic type of thyroid cancer, increases over time. So age effects on survival in well-differentiated cancer are dominated by papillary thyroid cancer in our current staging system. They have different effects for papillary thyroid cancer and follicular thyroid cancer. And the separate effects for these two types of tumors we're suggesting should be considered in future staging systems. I appreciate your attention and certainly, again, appreciate the opportunity to present here at this meeting. Thank you.